Yeah, I just had to turn around. Here you go.
Oh, good. Good morning, everyone. So it's my great pleasure to introduce our grand round speaker this morning, Dr. Stacy Watt, who's a clinical professor of anesthesiology at the State University of New York at Buffalo. So she has an incredibly interesting CV, particularly for someone at her level of career. She's got a big, thick CV, and she's got an incredible number of accomplishments and interests and so on. So if you get a chance to speak with her today, please do. She's going to talk to the residents separately after this, and then she'll be circulating in OB and Peds. And so I want to give you a chance to meet her. Just a few highlights out of that really big CV. She's a magna cum laude graduate of University of Florida, where she was a four-year star in track and field, had many regional and national athletic honors, including Division I All-American status in track and field. So she's the real thing. Yeah. So she got her MD degree from SUNY Upstate and did her residency training in anesthesiology and a fellowship in peds anesthesia at SUNY Buffalo. And she's been involved in many leadership initiatives, including the Harvard School of Public Health Certificate Program. And she's due to receive in 2020 both an MBA and a Master of Health Professions Education. So she's a very, very busy person. She's been the program director for 2 fellowship programs in anesthesiology in Buffalo, both OB and Peds. And she's the anesthesiology residency director at SUNY Buffalo. She, in 2008 to 14, she worked here in our department part-time. In addition to all the other things that she was accomplishing in Buffalo. And currently, she's got, I'm just picking a few activities out of many. She's chief of anesthesiology service at Kaleida Health in Buffalo. She's on the board of directors of the Malignant Hyperthermia Association in the United States. She's an international hotline consultant for MHouse. She's active in NYSSA, and we're hoping that she'll get even more involved with governance at NYSSA. And overall, just a wonderful person and a very impressive anesthesiologist. And so her lecture today is entitled Heat-Related Illness and Injury. Stacy?
Thank you. Thank you for that great introduction. All right, let me just make sure I got the clicker right. Excellent. All right. So for those of you who haven't seen me lecture before, I believe in sort of high impact lecture, and I brought candy to prove it. So if you interact with me, I'll support you in your sugar needs. So we have 2 people that are going to be assisting me. Raise your hand for a minute. I just want to say thank you to you guys. So they'll also have a plethora of different candies. So if you see something that you're either allergic to or need something else, by all means, ask for a swap if you can, but don't get greedy. All right. So as you know a little bit about me, again, is the mic okay before I go for it? All right, good. I'm a hotline consultant from Malignant Hyperthermia Association of the United States. There's, I think now 32 of us coming on and off the hotline. I take hotline call probably about anywhere from 4 to 8 times per year, 2-week runs. I get called at all hours of the day, and it is an entirely volunteer post that I hold. So we assist anyone that calls into the hotline and that's having a crisis or even thinks they might be having a crisis. So you see that 1-800-HYPER. You have a 1 in 32 chance of me picking up the line, and I'll greet you accordingly and say, hey, I hope you went to my lecture. So let's talk about what we're going to talk about today. First, we're going to do a brief review of MH, just to sort of get the wheels turning again. Everyone knows about it, but it's something that sometimes you have to be reminded of because it sort of goes in the back burner a little bit because it's one of those zebras that everyone thinks, I've never seen one, it's not going to happen to me. And that's when it happens to you. So we'll then talk about heat-related illnesses. And there's a plethora of heat-related illnesses. They're not just like a switch that goes off that you get like heat stroke or you don't. We're then going to talk about a little bit of a case discussion, talking about the importance of how these two relate. And then I always want to bring it back home. How is this and this lecture going to impact you and what you do and how not only you practice anesthesia, but how you go forth and really interact not only in the operating room, but your community as well. Because this malignant hyperthermia is not live only in the operating rooms. And then we're going to talk about next steps. What does this mean for M-House? What does this mean for you? And how can we move this forward as a community of anesthesiologists and really bringing this to everyone's attention? There we go. So let's again start our review. So let's talk about incidence, incidence and prevalence. So it's reported between 1 in 4,000 and 1 in 40,000 anesthetics. Why is it so broad of a number? Come on, this is where you jump in and you get excited, get more coffee. Why? Why could it be different? False positives are a good answer. What else? Variability. Regional variability, okay. Type of anesthetic used. What else? Okay, could be relatively rare, different sample size. So I want my two people that were really, get up, come on, you're getting engaged. Exercise time, let's go people. If you don't know, I'm a coach as well, so I can become booming. So if the mic level goes too high and I start to really yell at people, just say, okay, okay. Or take the coffee away, it's one of the two. You gotta find people. So raise your hand if you gave an answer. All right, so there's a different variability, and a lot of it has to do with also it's reporting. So a lot of people say, well, I don't even know about M-House. Some people don't understand that there is an M-House out there. And so the reporting is sketchy. So it's really trying to find out even forensically what happened to these individuals and getting that reports in. So a lot of it has to do with reporting, and some of it, again, might be a false negative, false positive. So there is a very big span in there. And again, there's a big argument on is it less, is it more? It affects every ethnic group. So there's nobody that's sort of immune to getting an MH reaction. And they say about 600 cases per year are reported to M-House. And it's pretty much static. It's every year. So it's not like it's sort of sloping or becoming less. It's just a constant number that sort of goes across. And there's some hot spots, believe it or not. And there's one in Wisconsin, Michigan, West Virginia. Why would there be a hot spot of MH? What do we know about it that would make it a hot spot? Genetics, perfect. What kind of, yeah, you got to give it to him. Come on now. So, okay, genetics, how is it passed? How is it passed? Autosomal dominant, excellent. So I have two daughters who are driving me nuts, but they're 11 and 12. I'll get into that later. So, okay, great. How, if I have MH, you know, what are the chances of my kids having MH? 50-50. All right, just start throwing candy at it. All right. So this is great, by the way. So everyone should, by the end of this, get candy. Yes, genetics. So half my kids should have it. That means both could have it. That could be none could have it. So, but are you, as you talk to me in my pre-op, are you going to be a little worried when I say I have the medical alert bracelet on and I say, oh, and here's my kids? Yeah, everyone will be like, nice. So, yeah, so what are the signs of MH? What do we first see? What do we see first? Tachycardia. Okay, what else? Louder. Yeah. You think to yourself, there's, you know, it's a laparoscopic case. I could just breathe this off. It's no problem. And then you're sitting there going, okay, this is getting harder, 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 harder. And then eventually all of a sudden you go, okay, stop. I'm like breathing this kid out at 1 billion, you know, and nothing's happening. My CO2 is still building. So yes. What else? What's a late sign? What's the one that when you see that you go, maybe this one a little far? Yeah, so the urine becomes that, what color? Red? Darker than that. Think Coca-Cola right in the Foley. So dark, dark, okay? So yeah, rigidity could be a letter, like letter sign, modeling, sometimes they say that. And again, many of these signs come, and they all come at once, oftentimes. There's not like a definite, you start here, and you progress to here. And by here, we're in now emergency territory. Sort of all comes at once, and it doesn't all come at the same time, and it doesn't all come together like this. So do you think that if you have maybe 3 of these, that it's MH, maybe? So if you had an elevated CO2, slightly elevated heart rate, and maybe a little bit of rigidity, would you be thinking MH? Maybe. You might be. You might be. It might be. It should be firing in the back of your head, you know, as you eliminate the usual suspects. So you go through and you look at it and you're like, okay, change the ventilation. I gave a little pain med, gave a little muscle relaxant. Nothing worked. And you think, dang it. That's when the call goes out of, I need some help in here. But yeah, you're not going to see the, like, all things come at once. That'd be like maybe a definitive firecrackers go off, you know, like in the movies when they see someone across the way and they realize it's them and, oh my goodness, yes, of course. No, it doesn't, rarely does it happen to that. All right, so again, like we talked, it's a spectrum, right? So not everyone also flips a switch and it becomes fulminant MH every time. It can be other things. So fulminant MH, does it occur? Yeah, absolutely. Trust me, I get the calls. Rigidity, fever, increase shortly after anesthesia. Usually they just start the gas and boom, like a firefight comes up. Then there's that dreaded masseter rigidity, okay? And it, you know, typically after succinylcholine, someone describe it to me. I'm counting on the professorial types in the room. I'm looking at you. Brick wall.
It is a brick wall. I've had one and
Yeah.
cannot open that.
Exactly. It is literally a steel cage. So it's not like the rigidity that you're like, I could sort of push a little harder, I give a little propofol, it got a little better. Oh no. It is literally like someone just sealed everything shut with cement. You're not moving it. So again, typical. And then late onset. So does it always happen right when you turn on the gas? Come on, people. No. All right. So it can become any time in this frame. So it can sort of happen in the mid case, it's a long case, after case, and it can happen in recovery room. And this is where, you know, our expertise extends. That's the first step out of the operating room. Is not only getting our patients ready, but it's taking care of them after our anesthetics. And we'll find it even extends, obviously, beyond that. So we have some muscle disorders that are associated with it. We all know these. Again, this is the warm-up phase. So central core disease, multi-mini core, Duchenne's, Becker, myotonias. Again, varying, anything that sort of affects that muscular pattern, you're looking at the kid and going, or adult, you know, they sort of are hunched over, they have some issues, they're complaining of muscle issues. You might want to start thinking this way. Because again, they sneak up on you. There are seats up front. Come on, people. Come on. I don't want anyone standing during my lecture. That's terrible. Come on, sit down there. So again, occult myopathies, central core, multi-mini core, Duchenne's, Becker's, they all have that MH-like episode that is on that risk that you should be thinking about. And so what do you do when you get those people? Do you just say, I'm sure it'll be fine? That's a bad idea, by the way. Just throw that out there. How is it? What do you do? What do you do? Punt? TIVA. Good. Do you educate them about what potentially, why you're doing a TIVA? What do you say? Don't worry about it. Just move on. It'll be fine. Hopefully then, you know, like someone else will take care of them later and, you know, let's see what happens. No, you're going to educate them and say this is why we're doing this. And, you know, maybe you could direct them to the hotline and you're going to educate them and you're going to be that advocate. You're going to be that consultant. Okay? So, okay, great. You know, they come to you. Yes?
Sorry, before you left, can I ask you a question?
Mm-hmm.
How often do you get, maybe this is earlier, but do you get calls to the hotline about what would have triggered in the factory by being around other people who breathe off gas? Like how likely is that to
I have had, the question to repeat is typically like, do you get called when you get people that are secondhand exposure sort of to gas agents that are exhaled? I have actually a lot of calls that I get from staff that are peds nursing staff that literally are in the operating rooms and they're afraid of triggering themselves, because you and I both know when we're doing a, ear tubes that the mask is on and off, or if you're doing something that, they're doing an eye probe, you're putting the mask on, you're taking it off. And what's happening while you're doing it? You're talking, the mask is pointed and you're sharing your anesthesia gas with everybody. And they're standing there often. So yes, we have had many calls in that regard. I always offer them to say, you, first of all, employee health is where you should be going first to make sure that that's on your information. And maybe this is not the exact specialty, because have I ever seen anyone trigger from that? No. Do I really want to roll the dice with them? Not really. Them inhaling anesthesia gas could be an environmental trigger. I'm not willing to risk their lives over my guess. So I always advise them to, maybe going into something that's out of OR would be beneficial. And like we mentioned, the Duchenne's and Becker's, they have risk of hyperkalemic arrest with sucks, but or other triggering agents, but not really MH. So again, there's things. Again, this is the warm-up phase, just like in athletic competition. We're warming up. Yes?
Always use non-triggering technique with Duchenne's, or
not always,
on their
no.
age? And I mean,
it depends on the age, what we're doing. It has a lot of varying things. So the question would be, if you got a Duchenne's, could you always, avoid everything as far as gas agents and do a total TIVA? Not necessarily. Again, we just obviously will avoid, a succinylcholine. I have done kids that have Duchenne's for spine surgeries, and we have used gas agents without episodes. Do I have a high degree of panic? Yeah, in the back of my mind, I'm always thinking, there's always that possibility there's something there. So not always. So I never say always, and you shouldn't either for your oral board exams. All right, muscle contracture test. So how do we know? We have to send them somewhere, right? So everyone always says, well, we'll just do the biopsy and we'll send the biopsy. What's the problem with that? Fresh. So the problem with that is, yeah, you get, my candy people are falling behind. Come on, people. You're watching. Yeah, he's like, it's him. Okay. So yes, you have to send them to a specialty area, because if you give that muscle biopsy and you send it in formalin, it's dead. So the chances of hooking it up and getting that muscle fiber to fire is about -5 of a chance to try to get that going. So they got to go to a specialty center. Very true. And there is a good way around that, and we can actually be a part of that. And it's something called a letter of need. You could actually get involved, for everyone's information, with the insurance company. They need a letter of need saying what exactly happened, why is it important, and there's actually a form letter on our website that you could go to, and we could guide you through that. And we could actually help get that covered for them. So we can be, again, outside the OR, we could be the advocates. We can help them get it done. Because who knows MH better than anybody in this hospital? They're all in this room. Anesthesia. We do. We're the specialists. This is ours. Of all things, this is ours. All right, and now this big thing's come on, and this is a very exciting part of M-House, and a lot of us that are Hotline consultants, and this is genetic testing. It's not taken over having that muscle biopsy, but it's getting close. We're sending a lot of people out there to get genetic testing for not only their families and everyone else, because it's a lot less scarring. It's a lot easier to do, and we're finding more and more. So currently there's 6 or 7, I should say, the 7th is under debate, of mutations that are identified as causative in the ryanodine receptor. So there's 7 things that if you look at the people's genetic codes and you see that code, you go, aha, we got it. And then that's what you could take and say, okay, great. You have MH and here's this gene you have. Let's get all your family tested. Because now we know what gene you have that triggers. And then they can help that family. Okay? So again, a lot of things. Now we're going to go into what we really want to talk about, which is heat. Heat comes in a lot. Everyone's like, oh yeah, that'd be nice right about now. so construction workers, those athletes, young athletes especially, out in the field, and our military. They're all at risk. They're all out there and they are at risk, and they're going to need us, believe it or not. So there's a lot of type of heat-related illness. There's one more. Here we go. So there's, get that, make sure. Heat-related illness, there's exertional rhabdo, and then there's the dreaded heat stroke. So again, it's sort of like flavors. It's sort of a continuum too. Heat-related illness and injury it's a very interesting thing. So as far as heat-related illness, it's a disorder. It's healthy people. They overheat, but they can't dissipate the heat. They sort of just build and build and build the heat. And then they could sort of slide into the heat stroke if not treated, or they get some relief in helping them dissipate the heat. There's exertional rhabdo. Some people have this too. They actually will overexercise, and all of a sudden their urine is Coca-Cola colored and they cramp severely. That's exertional rhabdo. There's individuals out there that have to be very careful when they exercise. And then of course heat stroke. That's when the CNS, the seizures, cognitive change, the core temperatures, they skyrocket to 40 degrees Celsius, 104 Fahrenheit. I've seen a few go up to, obviously 108 without any issues. They go, I mean, we're talking hot. So this is a poster that I always love because it was sort of stuck on one of the athletic training doors of where I visited in the Olympic Training Center. So heat exhaustion, this is what you're looking for, the signs and symptoms for the lay public out there, which I always thought was great. And I like when they have death on fire. That sort of brought it home to me, so I took a picture of it, and I thought, that's great. So nothing like scaring your athletes ahead of time. I like the silence. That was also my favorite. So a little bit of humor, but also to bring home it's out there, and at least they're doing something. They're reaching out to their athletes at that high level and saying, hey, you got to be careful. And that's something, again, we could participate in.
Stacy, what's exhaustion? Is that just hypovolemia?
It's hypovolemia. It's sort of cramping. They're not adequately hydrated. They're not seeking refuge. So they're out in the blazing sun in Florida at 2 p.m. in the afternoon, training for a marathon. Typically not the brightest people. Darwinism in effect, if you want to think of it that way. That's not the idea time to go out and run. And then, oh, by the way, they just ran out without any water bottles. And like they run in an area that has not a tree in sight, and no help around. Because that's great. So that is the heat exhaustion, where they literally, you'll see the runners after a big marathon sometimes vomit repeatedly, and they're cramping and they're dizzy and they fall over. That's the heat exhaustion that they hit. Again, heat stroke is right where you're getting into that really red hot, their pulse, they're collapsing too, and they're starting to hallucinate, they're behaving odd. Seizures, that's the neurologic components start to creep in. So everyone's like, well, how is this connected to MH, except for the heat part? And that's why it's very interesting. So we have case reports that say, yes, it's connected, and we have case reports that say it's not. So just like in anything in science, we have to find out more. And we have these case reports that say, okay, a child that has known MH episode later dies from exertional heat stroke. So they know that this kid literally came out, was exercising, and collapsed and died from heat stroke. We have a young man, malignant hyperthermia susceptible. It's called MHS, for those who don't recognize that. It developed rigidity and cardiac arrest during training for his police academy. Found to have all the triggers there and died. Okay, so you said, okay, that has to be positive. That must be related. And then we have those that aren't. So then we have a 16-year-old well-trained athlete, experienced, change in mental static, hyperthermia, distress, multi-system organ failure, survived, muscle biopsy negative. You're like, okay. Number of athletes, soldiers, suffer from exertional heat illnesses, test positive in some case, and they negative in others. For those of you who don't know about the military, if you collapse and have a heat-related illness or stroke, you're automatically tested for MH. So they take good care of those that protect us. So they get automatically tested. Sheila Muldoon, who is now recent retired MH, worked very hard to get categories and get all of her soldiers tested So if they collapse or they have a certain temperature level, they come in to see her, or they did. Now they see a few of her colleagues, but she's still actively involved. And she says, you get tested. I want to make sure that you're not going to go out there and you're going to die. So again, very active. So you say, okay, I'm a peds anesthesia, so you have to get kid. Now what does this mean? Okay, so could it be, yeah, they have heat-related illness and they're telling me during their history, you know, hey, by the way, I run a lot and I get cramping and I don't feel good and I've collapsed a few times. And they're now coming to you. You got decisions to make and you think, well, I remember this lecture. She was a little nuts. And I got candy out of it though, so I remember it. And you think, okay, so now what am I gonna do? I got a choice. I got a decision. I'm a consultant and I'm gonna think this through. I'm gonna talk and I'm gonna get the history and I'm gonna find out. But it comes down to really, what are you gonna do? Because I even confronted you with data that has positive and negatives, right? It went back and forth. So again, using your skills as a consultant, finding out more about, you know, how they presented, what they presented, how severe they presented. This all goes into you making a good decision. But I want to alert you it's out there. Because some of you might have think, well, if they have cramping, then obviously they didn't hydrate very well. And they need to be more, you know, in tune with your coach. You should talk to your coach more about training, instead of thinking maybe more about MH. So again, what does this mean? We need more data too. What does this mean also is we got to do more testing. We got to do more research. We got to find more information out there. We've got to make sure that we find how these are connected, and so we can better serve the patients we care for. We want to be able to find that definitive link, so when we see it, we say, oh, absolutely. Now you're MH positive, I can help you. So we've got to, again, find out more. And you can recommend some testing too. You could say to them, I'm listening to the story of how you collapsed in the field and you've done this twice, and I'm not feeling this whole history here, and it's bothering me. And you could send them to mHouse and say, I think you need to be tested. I think that this might be worth your while to get tested. Or you could say, listen, until that time, I'm going to treat you as this. Yes?
So, in the absence of really good epidemiological data showing the strength and association with related illnesses and these different muscular dystrophies, why not just treat them all as MH susceptible? You're done.
Great question. So why not treat everybody as MH susceptible, or even I'm taking it to the next level. All right, so I do that. Just bear with me. So his question is more like, well, if you get all this type of things and they're even at possible risk, just TiVo them. That's reasonable. That actually is very reasonable. If anything comes to a flag in the play, I call it, Ken, coach in me, yeah, why not? What would be the problem in doing that? Would there be a problem in doing that? Cash, I like that. Could be financial. But what's the cost if someone triggers? Dollar signs everywhere. Yes, that's because where are they going to end up? They're not going to end up in recovery, right? They're going to end up in the unit. Are you eating all the candy? Okay, all right. Because you're not handing out much. I'm just going to say it. Okay, all right. I see his arm going in, and he's like rooting around in the bottom of the bag. I'm like, really? All right. Okay. So, yes, you're going to recommend testing. But I've even had the people go further, and that's why I brought that out, to say, you know what? I don't even want to deal with MH. I don't even want it. Or they have had an MH episode, and they're punchy about it. They TiVo everybody. They say, I am the safest anesthesia person out there. I TiVo everybody. And I said, oh, wow. Because that's a lot of equipment, too, to do that. So, yeah. So there's financial reasons. And we have a gas agents. And again, it has to do also with comfort of other providers. When you're learning and teaching and that type of thing, someone makes a mistake, what's the first thing to do? Heart rate's up a little. The first thing they do is the hand goes on the machine. And if they're not paying close attention, and the sign out maybe it was great, but they just had a momentary lapse, they were tired, the machine got turned on. And that has happened. So yes, could you? Absolutely. And it's a reasonable thing to do. It really is a reasonable thing to do. Whenever anything faces you that you go, not today, you back up. that's a reasonable thing to do. But there was one case that I want to share with you that really changed my mind and how I really thought about this, because I was sort of on the brink too, and I thought, you know, there's not really good data. It could be back and forth. And then I heard about Vincent. And this is Vincent, and he's, in this picture, 6 years old. And Vincent died 2 weeks before his 7th birthday. And how he died, mid-June, he was outside playing, and mom comes home from work, and he's complaining his headache, he's sort of sore. But she's thinking, oh, he's been out playing all day in the sun. He's 6 years old. He's not exactly adequately hydrating, unless it's a popsicle. So yeah, he's behind. So phone rings when she gets home. He has him laying down. She's thinking of giving him some Tylenol because of the headache. And then all of a sudden, it's like the neighbors want to play with the kid. You know, there's a splash pool down the street. It's hot. And she's thinking, it's no problem. You know, he can go out and play with his friends. It's okay. It's summer. It's all right. But then 20 minutes after she dropped him off at the neighbor's house, she sees a neighbor coming up the drive, you know, with Vincent and the other son. And he's not acting right. And complains he can't bend his legs. He's sort of walking like that stiff walk. Can't bend his legs too good. Describes his mom, you know, my heart's pounding. I can't bend my legs. He's really hot to the touch. Like to the point where it's almost like, oh my God. So she grabs ice packs. She does what every mom does. Cool your kid down. He's overheated. She puts ice packs around his neck, under his arms. You know, she tries to get him to drink some cold water, thinking anything, put him in the shower. She's doing all these things, saying, okay. And then she's, okay, now this isn't stopping. Like, he's not feeling better. If anything, this is like building. She has the awareness to say, I got to call 911, but in her panic, she goes, wait, he's still cognizant. I could get him there faster. Something's happening fast. And I give it to her. She honestly was thinking, my son first. So she puts him in the car, front seat, because he can't bend his legs. And she's too afraid that if she breaks, he's going to fall. She gives him the fun packs, puts ice packs around him. The neighbor's helping getting him in the car. And she's driving to the hospital. She's noticed his breathing is becoming shallower and shallower and shallower. And his main complaint, though, right at the moment, was the sun's in his eyes. You know, Mom, really? You know, you're driving right into the sun. And she's thinking, well, at least he's talking. He's doing well. He's breathing okay. It's getting shallower, but I'm starting to panic. And then all of a sudden, he can't open his mouth. And he's talking through his teeth like this to her about how scared he is. And he's sounding scared, because now he's not only his legs are tight, his jaw is tight, and he can't talk. She carries him to the emergency department. She is in full-blown panic mode, because now the breathing's becoming shallower. He's not talking as well, and she hands him off. What do you think happened next? She hears code blue. And then she has the joy of seeing her son get resuscitated down the hall. And they tell her, oh, well, the temperature was so high, he must have been septic. And you know why it was 108? Why do you think the temperature was 108? Because that's as high as it went. That's as high as a temperature thermometer would go. We don't know how hot he got. So we often do hit these cases that change our minds about what's really out there. So everyone wants to know what happens next. So after Vincent's death, the medical examiner rules out anything contagious, because they said, oh, well, it's got to be an infectious etiology. It's meningitis. It is septic. This kid was ill. And she's like, no, he was fine. He didn't have she knew just enough to say, I don't think so. And she was this advocate and said no. So 6 weeks, the ME, to her credit, said, diagnosed on the death certificate, MH. Caused sort of a whirlwind in the MH community of saying, oh boy, we've got something here to educate and also help this family. So MH became involved. She had never heard of MH before. No idea what this is. And neither did her family doc. So before this had happened, she had taken Vincent to specialist after specialist after specialist, saying, you know, he hunches over and he's not, you know, he's fine, he plays, everything's great. But, you know, then they never detected that he was weak. He was always keeping up with the other kids, no problem. But he just had a sort of slight bump. So Vincent's lab was fern, because during the code they did pull it, and he had a variance, the ranitidine receptor mutation. Family got tested because we found the gene. So we went to the family, of which he had, you know, his brothers and sisters, his dad and his mom. Husband, 2 children, same variants. Same exact variants. Even husband went further and said, I want to be absolutely certain. Went and got muscle biopsy tested. Fulminant positive. And they have central core. And they're out there. I mean, they're out there. They're not physically affected. They're walking around just like you or I. They're there. And you might not detect them. So what does this change in how you care for your patients? I want to hear that from you guys. What is this going to do for you? And don't say anything, or you're going to get sugar rush from all the candy. I'll take that as an answer too. So what does this potentially do for your impact? Will it change how you interview your patients? Will you ask that question about, have you had, you know, heat-related illness or injury, especially if they have an athlete, or even if it comes up in causal, conversation? Will you ask? Okay. There's a lot of things that this could impact you about. So if a patient tells you about muscle cramps, or they're, you know, rubbing their leg, or they're like, you know, looking at things, or they're maybe just, you know, someone's telling, they were even having a conversation when you walked in the room about all the muscle cramps that they've been having and how they can't just seem to, they've tried dietary things and potassium supplements and all this stuff and nothing's working. Will that change how you attack, like not attack, don't attack patients, but how you attack the question with them, right? Will that change your, because the goal of any lecture is to change how you do things and make it better, make you a better consultant in the world of anesthesia. And also, this is my favorite, you're going to be out in the community. You're going to be at Wegmans. We love Wegmans. You're going to be out there at a sporting event. You're going to be out there with your kids when they're, you know, at that first soccer practice and everyone's running amok. It's like amoeba ball. Everyone goes around. You're going to be there. You're going to be out there among the community, and sometimes somewhere that kid, that adult might collapse in front of you. And I want you in your mind to be able to think, wait a minute. It might not be that, like what everyone thinks immediately. Well, they had an underlying cardiac problem, right? How many times have you heard that? They must have had, you know, that issue that they have with the heart, and it must be, they must have had that insulin problem. Or it must be like they have something else. But I want this to pop on your radar screen somewhere at some time, especially because in reviewing with the National Athletic Trainers Association and the coaches across the nation, I've done many lectures with them. I could tell you right now what their policy and procedures are. So if I am running, and I'm younger, everyone picture, I collapse on the field. Do you know what the coaches are trained to do? Come on. No, they're actually not even trained to get an AED. If I collapse in the field, and if I'm even like partially with it, they're trained to just basically get ice packs. It'll be all right. Get cold water and ice packs. And maybe try to get my temperature read. So do you think a coach brings their temperature thermometer with them out in the athletic field? No. And how many schools have an athletic trainer? I can tell you, not many. So I educate a lot of the coaches out there to say, that's probably not a good idea. You need help at that point. Always have your cell phone. Always have the ability to call 911. Don't wait. If they're collapsed, that's not the time to guess and hope that it is just maybe heat, you know, they got overheated, that type of thing. Especially if you start, and I teach them about the signs of MH. Because a lot of them, you know, they think it's a musical instrument. Or, you know, oh, or it's this really cool disease that somebody else has. And my athletes all don't have it, by the way. I said, really, did you ask him? They're like, no. And oftentimes they're kids. They're not going to come forth. And if they don't have the medical alert, it bothers them, it itches them. I actually found quite a few teams out there that did have an MH susceptible kid on the team and the coach didn't know. That's scary. So it's very important. Yes. So the question has to be with the dantrolene. Should the first responders have it with them? Should the coaches have it with them? What do you guys think? No, okay, let's start with a price tag on the dantrolene. Okay, how much is dantrolene? Ryan, let's start with like the Dantrium, the big vials. Like there's a lot of them. There you go. How much for the little one? That's higher. Usually it's crusting. I think the prices have come down a bit, but it typically actually per dose could be maybe upwards of $3,000. So do you think that, and how long, but here's the great thing, the shelf life of a lot of them have been 3 years typically. So that is actually, they're trying to work toward extending the shelf life. So when they purchase, a hospital purchases, it lasts longer. But it is a hefty price tag. So it's not like the typical like drug everyone can sort of carry in their pockets. It does become a higher price tag item. So am I an advocate for them having, I'd like to see every emergency department have to have it. Because where is that person going to go? Right to the ED. And if we're having cases and we're doing cases, how long will it take us to get our carts and our dantrolene down to the emergency department on a busy day? A while. Have you ever run a drill where you took your MH cart down to the ED to time it? I have. That was bad, by the way. I got a better cart after that because I was swearing halfway down. It took me, with the old cart, it took me about 8 minutes to get that cart from my operating rooms down all the way to the emergency department, through the elevators, and I timed myself. I did it twice for averages. I got a new cart, trust me. After that, definite new cart. Because it had everything I needed to help the patients in the emergency department. And a lot of JACO DNV, test you now. Have you done any training or education in your ED? Because again, if the coach can't detect it, or they do hopefully detect it, they're going to send it to the ED, who then has to alert who? You. Because when they have an MH episode, who's the expert in MH? It's us. They should be contacting us because this is our wheelhouse. And that's why educating them to saying, you get a heat-related illness injury and this kid's tight and rigid and acting funny and breathing shallow, like who? Vincent. Because you know what they gave Vincent when his jaw was clamped? They gave him socks. That took Vincent's chances of survival away. Now, not to say he wouldn't have made it, but had the ED provider known what they were looking at, there's a possibility. We could have got there in time, maybe. Sounds pretty far gone, but I'm willing to take that chance to try to save him. And I'm sure all of you are too. Right? So as consultants, we step out of the operating room frequently. And this is a big opportunity for us to step out of the emergency room, out of the operating room to the emergency room, to the athletic field, to the training departments, I'm lecturing to the Olympic Committee. This is important. Yes.
So that's assuming the ED knows what they're looking at. So what?
You do.
So that's assuming the ED, so them contacting us assumes that they know to contact us.
Yes.
So what sort of education, is there any standardized education that emergency is getting? Does this hit their boards even? How do they know what they're looking at?
And I've asked many of my ED providers, I give them a clinical scenario, I train some of their residents, and I could tell you under half get it, under half. understand, and also think, oh yeah, wait, I read something about that before. And I'm like, would you have caught it? They're like, no.
So that's
Because-
on us to get out to them.
Yes, it's on us, believe it or not. And you think, well, they should do it themselves. But you know what? This is a great opportunity. This is us. This is us becoming greater, in my mind. So we can make a huge impact in medicine. And this is a way we can also get out there and do it. Our ED is not that far away, and they need us to help them understand. So I run mock drills with them. And let me tell you, the first time I do it, they're all over the joint. Because I have them call to the operating rooms requesting that they get the MH thing and get assistance and help. And I can tell you 100% of the time, they're like, what am I asking for again? And then they see the cart and they're like, what's that for? And it's amazing how they have no idea what they're doing. And then after the first drill, they go, wait a minute, I saw the cart before. Okay, I got it. 2 weeks after the drill, they had a patient come in with rigidity, modeling, heat. They called, and we came down. It wasn't, but it could have been, and we could have saved that patient. But they were thankful we were there, and I was thankful that they called. Because I don't want to hear any more Vincent stories. I don't. So it's important, and again, we can make a tremendous impact on this. So again, the next steps, we need to find out more. We need to do more genetic testing, find more of the loci out there. We need to find what the relationship is between those that have heat-related illness and injury and MH. We got to find the path between the two. And those that have then the heat stroke and heat-related illness that are identified, we could say, I can help you. Or when you're giving, what questions can we ask to ferret this out and save some lives? Because I'm sure that out there are those individuals that have in their back of their mind, like they cramp at every exercise, but that doesn't relate to anesthesia. I'll be fine during my knee surgery. And there they go. And again, we need to educate. We've got to step out of that operating room and say, take it upon our specialty to say, this is us. This is us. This is, again, our wheelhouse. We're responsible in some ways for this.
I have another question. So you had mentioned that we could refer patients to M-House.
Yes.
But then what happens? So M-House might give advice to the patient, but then someone is going to have to be responsible for the advice and the follow through. And it's maybe hard to find just a consultant anesthesiologist to help them after you're done taking care of them. So what's the loop around?
Exactly. That's a good question, because we have a patient tab on our M-House website. So I encourage you all to go to mhouse.org or .com. It goes to both. And you'll see a patient tab. Hit the patient tab. And it'll go through sort of educational points. And it'll ask, you can even part of it, you can contact a consultant. And I spoke with I do a lot with the athletic people that come in and they have like all these muscle cramps and have issues in MH and they're exercising. I actually work with 3 people training. 2 for the Olympic Games, 1's for the NFL. And I help them, manage MH and being a professional athlete. But when it comes down to, they ask a lot of people at large, say like, I have all these issues. I say, give me the number of your primary. And I try to close the loop with the primary. And I send the primary information about MH, because I can tell you most of the primaries are like, what's that again? Do you really think they have it? I don't think, what do I have to do? And I said, you have to become educated. Here's what this person most likely has, and this is how you can help your patient. And then I send all that data also to the patient for their own files. So I said, you change doctors or anything, you take that with you. And you start looking into it and educating. So I try to close the loop. But I can tell you there's patients out there that they'll get the information and go, ooh, that sounds scary. And they don't want to tell you what their primary is. They might not even have a primary. Or they don't want to even go forward in it. They find out about it, it seems scary. And how many people do you know avoid the doctor because they might tell them something scary? My mother. So it's a lot of them. They're out there and they hear about MH and they go, oh my God, that sounds terrible. I can't have that.
But you're closing the loop with your M-House cap.
Yes. With my M-House cap on, I close the loop by reaching out to the primary. But I also, for those that don't have a primary, I give them the information. I said, please contact me back. And I actually put them on like a hold registry that like if this person calls in, and I put a little note in. So I try to at least that information doesn't get lost. You know, and I give them even my contact number. You have questions, you call me. I'll find you. You know, that type of thing. So because then they become comfortable with me. So I try to close the loop. I try to educate. Yeah.
You said that you put them in some sort of a registry that's available to all 32 consultants. Is that right?
Yeah.
So
well, we actually put in data. There's called an strong work. So there's an actual malignant hyperthermia registry, but the note where I put them in is sort of like a note that's shared by consultants, and I'll even put it. We have an email that goes to all of our consultants, and it's constantly going with emails. And I put here's the history, here's the information, here's the note, and they all go, oh, okay. So if I get called by this person, I'll sort of have in the back of my mind. And I put it also, we have a depository.
So if we ever call with like concern about maybe my patient is having MH, give the full name to the consultant as well, because they may be able to cross-reference that person has been called in before.
Possibly, but the first thing that hotline consultant is going to do is going to get you to officially help that patient and guide you through an MH crisis. So when you call 1-800-HYPER, MH hyper, you're going to get a consultant. And the first thing though, when they get the phone, you're going to get actually a first alert person on the line. They're going to get your information. They're going to get a little biostatistics about the patient, and they're going to I'm going to get you a consultant on the line. Hold on. Then the call goes out to the consultants on call. We pick up the line, and then our first priority is to make sure that patient makes it out of your OR. So we are there to even problem solve. So if you're not even sure, you're thinking to yourself, maybe. I don't know. I'm not sure. It looks like it, sounds like it. Could be a duck, might be not. You know, call us. I get half my calls are sort of like, maybe. And a good portion are absolutely not. But I'm still here for them. They have a full-blown sepsis, great. They have a bath salts thing that, trust me, got way too many of those calls. And they have like this fulminant temperature. They've had a stroke. They have temperature regulation issues. All of that comes into play. I help them through all of it because I can, and that's what I signed up for.
Sorry, one more question.
Sure.
So just to use an example of Vincent, you know, when he started getting the leg rigidity and the muscle rigidity, do we have any idea what the time course is, or how much time we have before we give dantrolene, where it's
that's a great
actually going to
question.
help him? Or
the great question is, and I get this, that I use this information a lot of my drills. From the time you detect it, you typically got about 5 minutes to really get that dantrolene in. That's not long to start. Remember, dantrolene is that fire extinguisher. It's the one almost antidote that you have. So you've got to move. That's why doing drills and moving that cart is important. So if you haven't pushed the cart in a while, that MH cart, I want you to try it. Because if it goes squeak, 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 and it's scratching on the floor, you need a new cart. Or you need one with a lot speedier wheels. I mean, you've got to get there. Vincent's time frame was actually longer than that. So he might have been past the window of getting reversed. But again, she said she drove like a banshee around people. And she got to the hospital in, I think, 4 minutes, flat. She was gassing it down. Move, talk faster. Got it. I thought I was looking at the clock. I'm like, got it. Click, click, click.
What is the triggering agent in these patients that don't get succinylcholine or volatile agents?
So what is triggering them?
Yeah, what is triggering them?
That's what we're still trying to find out. But they believe it's like sort of a cascade. So when the patient starts to overheat, overexercise, a cascade is triggered. And that cascade suddenly starts that release, all intracellular release, and all of a sudden it just starts to just like MH. When you start that crisis, it's like a fire. You could think of it in your mind like that fire. It gets stoked, it starts as embers, and then whoosh. And all MH, again, it doesn't all follow the same pattern. So it doesn't always go like the huge bonfires, unfortunately, in Australia. It sometimes smolders for a while, then all of a sudden picks up slowly. Not all MH episodes act the same. So you might typically have 5 minutes. Sometimes you might have a little bit of a longer window if it's like slowly going up, but sometimes it comes up so far and so fast, you never had a shot. So there's a lot of these things that again, not many MH episodes always act the same. They're very different.
I think we'll have to end there, Stacy.
That's us. Good timing.